Buenas tardes, can you hear me? Yes? Good afternoon. Thanks for the invite to present at this important conference and event. I'm going to talk about recovery processes grounded in social justice. My name is Haner Hernandez, and I am Puerto Riqueño. I'm Puerto Rican. I've lived in Massachusetts for the last 50 years. And yes, I earned a PhD. I'm a certified prevention specialist, and I am certified and licensed as a drug and alcohol counselor. But I also have a GED, and my GED I got in prison. And it was more difficult to get a GED in prison than to get a PhD out in the real world, right? Out here. It was more difficult to do that. And as we talk about stigma and think about how to deal with stigma, one way is to use data that bores people to death. Another way is to talk about personal stories that bring people into the fold and give hope to people who are still mired in using substances across the country and here in Massachusetts. So we have a responsibility to do that and to do it well. So I'm a person in long-term recovery, and what that means for me is that I haven't used a drug in the last 32 years. And I am happy to say that I am a billionaire. I have 1 billion seconds in recovery. It's the only time that I'll be able to say that I'm a billionaire. But know that I worked in the field. I've worked in the field for 31 years, going on 32. Someone gave me an opportunity to work in this field when I just had that GED and I didn't know what I was doing. And I was taken aback because I said, these people are crazy. They gave me a job. I don't know what I'm doing. I don't think they know what they're doing. The piece in that story is that someone believed in me more than what I believed in myself. And we have a responsibility to do that with each and every person who needs help in our country, in our state, in our communities, in our agencies, in our neighborhoods. And I can't say that we always do that. I think that there's too much finger waving and finger pointing at people. We say that we understand the disease of addiction, but many times our response is riddled with stigma and a lack of understanding of what addiction is. So I worked in the field for 10 years with my GED, and I sat in rooms such as this, feeling inadequate and not brave enough to speak up, because many of you, many of us, many of lead with, well, let me answer that because I have a PhD, or let me answer that because I have a master's degree, and let me answer that because I know this because I work here. And the people who have a contribution to make in our country, people in recovery who might not have had access to the types of education institutions such as this one and others, have the same fears that I had, that I continue to have, that we need to make these spaces welcoming for those people. I can't tell you how many people called me and said, you're going to be speaking there? You're going to be speaking at that conference? I would like to go, but I don't know if that's a conference for me. You see the message that we sent to many people who need access to this type of conversation. I'm a person who talks a lot, so I have 11 minutes and 31 seconds left. I might say some things that are definitely going to make some people feel uncomfortable. And what I say to you is, when you feel uncomfortable, good. Because nothing has ever changed in this country or all over the world unless we make people feel uncomfortable. Nothing ever changed in my life unless I was uncomfortable. And if you feel uncomfortable, find someone to give you a hug, find someone, right, to speak to, that sort of thing. And then remember this, there are people today who just learned that someone died. There are people today who are planning a funeral. There are people today who are putting people into the ground. There are people today who are celebrating a birthday without their loved one with them. So if you feel uncomfortable, imagine what they feel, and then deal with it that way, right? Because if I feel uncomfortable, at the end of the day, I go home, right? But the people that we're talking about, the issues that we're talking about, are that serious for me. And so there's some people in the room who are going to find validation in what I say, because some of the stuff that I say is not traditionally spoken of in spaces and places like this. And so history and context matters. It matters for what we do, and it matters that we look backwards so that we don't continue to repeat some of the same mistakes that we're repeating today. And so we know a great deal that we have created silos. Our system of care is riddled with silos. We have mental health in one area, we have health in another area, we have human services somewhere else, we have addiction services or substance use disorder services somewhere else, and many times they're in the same building and people don't talk to each other. And we have a responsibility to address those silos and to do something differently. We have a responsibility to do that with policy, with actions, with behaviors, with our words, and we need to speak to these issues out loud, because the people who come to us, they are whole individuals, and we have developed systems, and we recreate systems that are fragmented and treat people in a fragmented way. You have a mental health issue, go over here. You have a substance use issue, go over here. And then these people don't do well speaking to each other. There are models to follow that we are breaking down silos, but we're not there yet, and we shouldn't celebrate or pat ourselves on the back thinking that we're there. We're not quite there yet. The other thing is that our field has traditionally utilized punitive measures to treat substance use disorders. And we can't get away from that, and we continuously need to look at what that looks like, right? So funding, most of the funding for substance use disorders goes to what? Goes to treatment, right? It goes to treatment. Do we fund prevention? Yes. Do we fund it the way that we need to fund prevention? No. If you have kids and you're sitting in this audience, you want your kids never to have to need treatment, right? And so communities want that too. And we need to fund the entire continuum: prevention, intervention, treatment, and recovery supports, not just one portion of it. The other thing is that we have a flawed design. As far as I'm concerned, and what some of the research says, we have a flawed design in terms of how we roll out services and for whom and how are they designed, that sort of thing. We have a system that was designed for primarily white heterosexual males. That is problematic if you are a female, if you are a female with kids, if you are a female that's monolingual, if you are a female with kids, monolingual, and is gay, lesbian. Where do we go? Where do we send people? There's a flaw in our design in terms of how we do things. And many times we're replicating those designs in ways that have disproportionate impacts in our communities. If people have relapsed in our field, traditionally we've kicked them out. And if you notice, I don't have traditional slides. My slides are nothing like maybe you saw this morning or anything else that you see in the afternoon. I can do those types of slides too, and I do them, but not here. And so when people exhibit signs and symptoms of their disease, we have kicked them out of treatment. We still do that to this day. I meet people every day in my community and across the state and across the country. They said, you know what, someone kicked me out. I just met someone who said, I was a recovery coach, and they told me that I can't be because I don't have 2 years in continuous recovery. But I have 18 months, Haner. A person with a huge heart with something to give back. We have a flawed design in how we treat our people within the workforce, and how we treat people walking through the door in need of services, or most of the people who are coerced into our system. The other thing is that we have locked people up. And that is a disgrace, and we should be appalled by that behavior. But it's not only that. We need to dive deeper. We have criminalized pigmentation of the skin, texture of the hair, accent, and all of those behaviors. We must never forget that we are in that space. We are in that space where my brothers and sisters are sitting right now in Concord, in Framingham, in Walpole, in all of these states and county jails across the country, and here in Massachusetts, serving time. And the majority of them have a substance use disorder, and over 50% of them have a mental health issue. So we have criminalized health. And we should speak about that out loud and up front. It's not enough to just mention an opioid crisis. So we have mass incarceration. In 1970, there were 200,000 people incarcerated in the U.S. And right now, we have 2.3 million people incarcerated in the U.S., disproportionate number of African Americans and blacks, Native Americans and Latinos, and poor whites. And so something is happening within this system that we don't talk a great deal about. There's a lot of research and some talk about it, but where are the policies? Where are the practices in relationship to these issues? And do we have an opioid crisis? That is the question. Some of you might say, yes, we do, and I say, no, we don't. When we have a myopic view of what the crisis is, then our policies are myopic in solutions. And so we have a crisis in the criminal justice system. We have a crisis with substance use disorders that goes above and beyond just opioids. See, we have people using methamphetamines. We have people dying from alcoholism. We have people, right, with all kinds of substances. We have a crisis in health. We have a crisis in education. We have a crisis in mental health. We have a crisis with affordable housing at the community level, with employment opportunities, and we should be comprehensive when we talk about what the crisis is, as opposed to talking about just one piece of the crisis. Because when we focus on one thing, then we get what we get. Why do we declare a crisis now? And some of you will feel uncomfortable when I say this. We have a crisis now because young white kids from the suburbs are dying. And that's why we declared a crisis. But in the communities that I come from, we've been living in a perpetual crisis for decades. And what we've gotten, instead of a conversation about treatment and prevention, is prisons and jails and punitive measures. And if you wonder why the audience looks the way it looks, it's because of how we do things and how we talk about things and our failure to be honest with ourselves in terms of what's happening. And our failure to look back and understand and look forward to understand what we've done. For people who look like me, who speak like me, who end up in prisons and jails when what they need, the only reason why I'm standing here with you today is because I got treatment. We need a process of humanization. Paulo Freire talked about the process of humanization. We need to wrestle back our humanity because we have been robbed of our humanity. And I would argue that each and every one of us in this room has been exposed to dehumanization in relationship to substance use disorders and mental health and other health conditions in the country. And if you don't believe me, when you leave here today, you're going to come up at a street light and you're going to see people with a sign. And that sign is going to say, we'll work for food. Homeless veteran. I saw one interestingly the other day that says, need money for weed and pizza. I'm like, oh shit, he got it right. Forgive my language. He got it right? You smoke some weed, you get the munchies, you want some pizza. And at that person, we have a different attitude than the person who stands there without a leg, who says, I'm a veteran. Why is it different? Because we have been dehumanized. We talk about, we're not biased, I'm not biased. I'm not judgmental. I treat others the way that I want to be treated, and I treat everybody the same. All of that is a crock of shit. We are extremely biased individuals, human beings are. We are highly biased, and if you're sitting in this room and saying, I'm not biased, you are, you're just judging a lot of people, or you're judgmental, I'm not, you're judging a lot of people, then you're judging me too. Because either you agree with what I'm saying, or you disagree, and that's a judgment. And we shouldn't be treating people the same. You are not the same as 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 you, and so forth. I have no business. It sounds good, right? It sounds good to say that we treat everybody the same, but we shouldn't. We have a lot of similarities, but we have a lot of different needs as well. We need to fund a true public health approach. The entire continuum, prevention, intervention, treatment, and recovery supports, and not just one thing. We need to be strength-based in our approach to these issues. We need to be trauma-informed, but we also need to be social justice-informed. Let us never forget that the data that the Commissioner of Massachusetts presented, right, talks about disproportionate impact. African Americans and blacks are dying at disproportionate numbers in this state. Latinos and Native Americans are dying at disproportionate numbers. And when we have a myopic view of what the crisis is, we come up with policies that are myopic and we feed disparities in our country and in our Commonwealth. We have a responsibility to address this in a different way. And that includes the multiple pathways of recovery. You know what is the most talked about pathway right now? It's been talked about at this conference nonstop. Medication-assisted treatment, medication-assisted recovery. And many people are talking about it like that's the thing for everybody. Medication-assisted treatment for everybody. Medication-assisted treatment works. And I know plenty of people where that works, but that is just one pathway of many. Many. Most people get better, if you read research, most people get better even without treatment. And so we have holistic approaches. We have exercise in recovery. We have faith-based in recovery. We have medication-assisted treatment in recovery. And we also have harm reduction at our disposal. And if you cannot support any one of those pathways, just get out of the way and let someone who can do that work and do it well. But don't be an obstructionist getting in the way and saying, oh, we shouldn't have safe injection sites in Massachusetts. Why? Are you going to use them? No? Then get out the way. Because I know plenty of people who can use them. I know plenty of people who can use them. We need criminal justice reform in this country and in this state. And it's not just about criminal justice reform. We also need restorative justice. Right now, the last data that I read, Massachusetts, about $200 million made from the sale of marijuana. The people profiting from that are by and large white heterosexual males. While my people sit in Walpole, Framingham, and all of the county jails across the state, across the country, for the same marijuana that is now legal to sell. But our people get to sit in those jails doing time. We have a responsibility to speak truth to power and to do something about that, right? I just got the time, and I'm over time, but I just have one more slide. This one. Our workforce should look like the people who are walking through the door. Right now, it's majority baby boomer, retiring, and white. The majority of the people walking through the door are young, dynamic, and very diverse. And so we need a workforce that is reflective of the people walking through the door if we're to get the results that we want, right? So I crammed a lot of things into 15 minutes, and I'm over. But we need to ground our work in social justice. There is no other way to do this as far as I'm concerned. And I am sick and tired of going to spaces and places where people are not acknowledging what is right in front of us. And if we want to lead with data, there's plenty of data on disparities and what that means. And in my house, we are as healthy as the sickest person in the house. And if you have kids, you know what that means. That if you wake up in the morning and your kid is sick and you woke up feeling really good, as soon as you find out that your kid is sick, you're not that happy anymore. And I think we can do multiple things at the same time. We should treat the most vulnerable populations amongst us, and then everybody gets better. And not just think about certain people as an afterthought. I thank you again for inviting me, and thank you for listening.